Thank you. Can everybody hear me okay? So the talk today, as people can see, is entitled The Impact of Trauma, Type and Incidence of Trauma in Adolescence, Showing Emerging Traits of BPD, Treatment Considerations and New Clinical Approaches. So the impetus behind looking at this now has been that as people have continued to work on BPD in children and adolescents, one of the very important phenomenons that we've observed is how frequently it co-occurs with a history of trauma and the occurrence of PTSD as a comorbid diagnosis. So when Brian was giving his talk and talking about bipolar co-occurring, people talk about substance abuse co-occurring, but nothing really co-occurs at a higher rate than PTSD with BPD, almost no matter what age span you're looking at, but certainly in children and adolescents. And at that point, I also have to distinguish between having a history of trauma and having PTSD. So it's important to know, which I'm going to discuss under assessment, whether a child or adolescent you're working with has a history of trauma. It's important to try to look at how the trauma interfaces with the BPD features. You can't necessarily tell causation, but it's important to try to figure out how they interface, and also to determine, because again, someone has trauma, only somewhere between 30 and 50% of people that are traumatized go on to have PTSD. A lot more people have acute stress reactions and do not develop full PTSD. If you don't have PTSD, we don't have to treat the fact that you had a history of a trauma. We're only treating the diagnostic entity of PTSD. But one of the things that happens with adolescents with, I'll call them BPD features, is they are ruled out for PTSD treatment because of their self-injury and suicidality, things that Jill and other people have talked about, because of their imminent possibility of self-harm. And they also engage in other high-risk behaviors or show dissociation. I'll go through a list of the rule-outs. But what we started to observe was that the pendulum, I think, as people know with PTSD and abuse, treatment of abuse has swung all over the place in the last 20 years. We went from an era where, courage to heal, if something happened to you, your therapist asked you, you told them, you spilled all. And there were a lot of negative antecedents, consequences, to that, in terms of people getting destabilized, not having skills on board, which weren't necessarily called skills, but not having the proper supports in place, their safety from people in their environment, and they'd plunge into treatment and become dysregulated, become self-harming, or have a huge treatment dropout rate. There was also the problem with the false memory issue, which there's no time to go into today, with Elizabeth Loftus and other research, which led people to the very strong conclusions, particularly with children and adolescents, that if a therapist that's important to them leads them and asks them enough questions or suggests that their symptoms could only be possible if they were traumatized, unfortunately, people will come up with trauma symptoms, not meaning to make something up, but they're also trying to make sense of their lives. So there's so much data and information that had to go into finding a balanced approach to trauma. And so we became interested. Blaise and I have worked together for 12 years or more. And that was before we had a unit that was dedicated to treating youngsters with borderline personality, emerging features. And we had a generic ART. We still have that. We started back then to try to look at the incidence of trauma and figure out, is this really a maelstrom because it's so popular in the literature? And so when clergy abuse comes up, or when Jerry Sandansky, whatever comes up in the press, then people turn their attention to looking for trauma and abuse, and then it swings away, and we see all the problems with it. And we were trying to find a very balanced approach to diagnosis and treatment where we weren't suggesting to kids that they had it, but neither were we ignoring it. So what we started to look at was the hospitalized adolescents on our generic unit. And the literature says that as high as 93% of kids that get to the hospital level of care report at least one serious traumatic event. And we examined 234 sequential admissions to the McLean ART, And we had 73% that reported, and traumatic event meant on our different questionnaires. It couldn't be something minor or fleeting. It had to really present a danger of safety to themselves or witnessing something that was potentially lethal. And of those youth, 50% had PTSD, 50% didn't. So it was 50% of the 75%. So pretty much over 10 years, this is held up, that on any of our units that we treat adolescents, about 30 to 40% of them at any time have clinical PTSD, whatever the comorbid diagnosis is. And it's obviously very tenacious once it develops. And the interesting thing is, we already knew from the research from John Gunderson and Mary Zanarini that for the adult population, having childhood trauma, particularly childhood sexual abuse, having untreated trauma was a huge risk for developing more severe PTSD, for it not remitting as quickly as PTSD without trauma as a factor, and also for greater co-occurrence. So in some of the longitudinal data, also that Brian presented some of, having trauma or maltreatment in an adult's history from way back when they were children, because these were older adults, remains a serious risk factor for how they do with their BPD over their lifetime. So obviously Blaise and I and other people came to the conclusion that if we could pay attention to it without suggesting it exists when it doesn't, perhaps, not making it more focal than it might be, but actually assessing PTSD and then figuring out, can you treat that in a co-occurring population that has self-injury and self-harm often as the major presenting factors. Because theoretically, if you can treat it earlier, it will not become so tenacious. And also, as I'll go on, there's a lot of evidence that DBT alone does not help PTSD. What we found initially, some of these kids obviously had overlapping traumas, but one of the things that was interesting, even way back here, I think this was 2007, but this was sort of at the beginning of when bullying has become such a rampant problem. So if you see, that was the highest single category was school violence. And this really meant kids that were, locked in lockers, beaten up, threatened over the internet, bullied in a very serious way. And there was a fair amount of sexual violence and other things that people have alluded to, like having a chronic mental illness or medical illness in the family by a sibling or a parent. These are all categories of things that are traumatic, both for the patient, the identified patient themselves, as well as for people in the family. So this gave us a baseline. We also, the literature is very clear that childhood sexual abuse in particular is a strong predictor of substance abuse, and that up to 20% of all suicide attempts worldwide, the World Health Organization, anyone that looks like this, at this, they tend to attribute that percentage of adolescent suicide attempts to having some very significant history of trauma and PTSD. And particularly childhood sexual abuse is the largest risk factor, and those victims are 8 times more likely than their non-abuse counterparts to attempt suicide repeatedly in adolescence. And they also have more high-risk behaviors than adolescents with sexual abuse-related PTSD. So a lot of the other high-risk behaviors we see, some of which fall under the criterion behaviors, and some of which just generally, if a criterion behavior is impulsivity, then many of these behaviors, particularly in adolescence, earn you one of the criterion behaviors for BPD. And this is often quoted that adversity in childhood is estimated to account for 44% of psychiatric disorders. So, I don't have to go through all these, but just the point here really is that individuals with PTSD alone, without a comorbid diagnosis, when it's untreated, chronic PTSD, it's associated with a lot of lifetime suffering and a lot of unsafe behaviors and suicide, and it's way up there with BPD. It adds another component of risk in terms of if it's untreated and people can't get symptomatic relief from it. So even though self-harm and suicidal ideation behavior is not a criteria for earning a diagnosis of PTSD, I think it gets confusing. People don't realize that just having PTSD alone confers a risk of having self-harm and suicidal ideation behavior over the course of your lifetime. It's just not a criteria for having the diagnosis, like it is one of the criteria for BPD. So, and in treatment-seeking populations, you'll see how high the level of self-injury. This is just with one diagnosis. It's as high as it is for BPD. And people are at risk for a whole bunch of things. We looked at this. Now we're still in a generic population of adolescents. We gave them the risky behavior scale, which we use a lot. And if you see the difference between no trauma and trauma across the 4 categories that scale measures, they're hugely significant. I'm going to skip the substance abuse because we're not really focusing on it here, but these are still very interesting. This is history of maltreatment, no history of maltreatment. So interestingly, for the substances that are commonly used by almost all adolescents, alcohol and marijuana, there's not a significant difference between the traumatized and non-traumatized group. But for the more serious substances that are less universally used, amphetamines, cocaine, there was a significant difference. So a history of PTSD and trauma that confers PTSD on you gives you a serious lifetime risk of being suicidal and self-injurious and not adapting as well in all areas of work and social relationships, et cetera. So what happened then, we already knew this, is we opened our unit, 3 East, that is for youngsters with emerging borderline personality disorder. And at that time, people were already starting to look. Again, I think as Jill or somebody pointed out, it's always been in the DSM, but people have been loath to use it under 18. But as people started to look at prevalence, a lot of studies are starting to show that it's found to be more prevalent in the adolescent population than it's reported to be in the adult population. And this is a time, again, as people have said, where there's a lot of behavioral unrest, impulsivity, poor concentration, identity disturbance. So it's not surprising that if you measure it at the features at a younger age, that you actually could get a higher prevalence. And as I've said, in the adult population, childhood trauma is, these are the statistics that people have found over and over again, that it's the low of 20% I've ever seen, but somewhere between the 33 and 58 that Hart and Linehan report is thought to be the prevalence. And that in adolescent populations, only a few studies, a very few, look to see whether we would find the same relationships that, like Zanarini and Gunderson, other people found, which is that if you have trauma and PTSD, that your Criterion B behaviors will be more severe and more tenacious, even without even suggesting any causality. It's not that the trauma caused the Criterion B behaviors or vice versa, because it goes in all of these directions. People that are emotionally reactive and sensitive can incur greater lifetime risk of being hurt in certain ways because their social relationships can break down. They can have differences in caretaking, feel a greater sense of abandonment, loneliness. Those are the kinds of things that drive teenagers into situations where they can get victimized in the first place. And many of our kids had abuse that either co-occurred with or preceded the Criterion B behaviors, and that's something that still needs a lot of research to see how those two co-occur. Trying to replicate John and Mary's work. So we wanted to see if the levels of childhood maltreatment compared to the adult, and whether more frequent maltreatment and more severe is associated with more severe BPD behaviors, and explore whether maltreatment history is differentially related to the treatment response with just pure DBT, which is what our unit does. And then the last is sort of the exciting lines of the future, is that Melanie and Marcia and people at BTech have developed a prolonged exposure and DBT protocol, which I'll discuss a little bit, which for the first time has reintroduced the idea that we can't just take a position if we find that all these relationships hold, meaning that trauma makes your behaviors more severe, your Criterion B behaviors more severe, you have more of them, that you're suffering with the PTSD and with the BPD. So to tell somebody in that situation that you have to wait a year to talk about this, you have to absolutely have no imminent self-harm and no target one, no self-harming behaviors for a year, we noticed it was essentially driving our kids crazy in a certain way, because they would develop a relationship. Again, as some of the studies that have been presented, by 9, 12 weeks, they would have some skills on board. They didn't have any target 1 behaviors left, and we were saying, okay, now you just have 9 more months to go before we can talk to you about your trauma, because that is what the literature said. People at BTEC started to gradually, and other people, move it up closer and closer to the time of the last self-harming episode to see if we could get these kids some relief with both the BPD symptoms as well as the PTSD symptoms, because another thing you frequently hear is that the PTSD symptoms are triggers for the target, for the self-harming behaviors to come back. So to assume you can stop one kind of behavior for a year before you start treatment for PTSD just is not true in this population. These were the people. We looked at 157 adolescents on our unit. These are their ages, length of stay, and we did a lot of pre and post assessments. This is the prevalence of trauma this is just an adolescent BPD population. So it was roughly the same as the first bar graph, wasn't a pie chart, which is about half the kids on 3 East report a trauma. So this isn't PTSD yet, this is just that they've had a history of a trauma. And the largest group is childhood sexual abuse, serious emotional abuse and neglect, serious physical abuse, and sexual plus others, mean they had multiple kinds. So this did not include school violence, things like that. This was really things that happened in their family, extrafamilial, but it wasn't bullying in school. And we did this with the childhood trauma questionnaire. There's a lot of different measures. So once we found out that's about the rate that John and Mary found in their adult cohort, we got the same results they did, even though this was a pretty modest samples, which is that adolescents with moderate to severe trauma report higher initial levels of borderline psychopathology. So when we did the initial clinical interview, when we did Mary's ZAN-B, the MSI, BPD, whatever measures we did on the way in, kids that had a history of trauma came in with more severe emerging BPD than kids without a history of trauma. There was also a very robust association between childhood emotional and sexual trauma, those 2 categories in particular, and the severity of the borderline psychopathology. So those were the most outstanding, more than physical trauma or neglect. And adolescents with a trauma history also reported significantly greater behaviors on the risky behavior scale, which I showed you before, the categories of self-harm, aggression, sexual acting out. And this one was more correlated highlighted with total physical and sexual and not the emotional category. This shows you just graphically the difference. It was really astounding how different it was. And their risky behavior was less. It was still almost significant. And what I'm going through them somewhat quickly. I know people want to also ask questions. So this is the change that we get on the unit if you take trauma out of the equation. So we wanted to see, will the depressive symptoms, because that's the other high category, if kids were not being diagnosed as having BPD, most of our kids would be diagnosed as depressed, because Blaze doesn't diagnose anyone as having bipolar illness. So they'd have a unipolar depression if we had to give them a diagnosis, and we were still leery to give them a BPD diagnosis. So those were the 2 major categories. They do get better over the course of treatment, as people can see from pre to post, regardless of trauma. But then what we wanted to see is what Melanie and Mark have been highlighting, which is that straight on DBT doesn't help with anxiety disorders. It helps with mood, it helps with substance abuse, it helps with self-harm. So it helps a lot of mood and behavior symptoms, but it is really anxiety disorders are pretty intractable to straight on DBT, and that was something that, Marcia and Melanie were unhappy finding. They still had, 83% of their samples still had anxiety disorders and PTSD. So we tried to look at the same thing to see if just over the course of our program with no specialized treatment, and you see the cutoff point for this PTSD measure. So both groups started off with having significant trauma, but only the kids, when I say no trauma, these kids reported a trauma that was, I'm not saying it was insignificant, but it wasn't a childhood trauma. So for example, some of the traumas in the no trauma group were thinking back to when somebody remembered themselves hanging. They had been hanging in their closet, their mother cut them down. some sort of serious motor vehicle accident in which a friend was killed. So we had a number of people who qualified. I think it's another risk factor, and I think Jill spoke to this little, the more bad events you have in your life. So we have a lot of kids come onto our unit who don't have childhood trauma, but they've had traumatic things happen to them. So that's why the no trauma, I think, qualified for PTSD when they first came in too. They did get better, and the kids with serious trauma, the red line, did not. So 56% of patients with histories of childhood abuse for us still met clinical criteria for PTSD at the time of program discharge, and patients with history of childhood maltreatment showed relatively less change in PTSD scores. And they also reported using the BPD criterion behaviors as a way to manage their PTSD symptoms. So, again, Jill talked about being, radically authentic in your relationship, and we were constantly, kids would say, okay, I haven't cut in weeks. Look at my diary card. You say you want to have this really genuine relationship, and hear what I have to say. Well, what I have to say is, I'm dwelling on this thing that happened when I was younger. I've got nightmares, I have flashbacks, I'm avoiding things. And those problems are driving my Criterion B behaviors. So if you won't talk to me about them, I am eventually gonna cut again or drink or do something because I'm suffering. And it wasn't in a threatening way, it was in a please could you address these issues way. So we were sort of stuck because at that point the guidelines in the field said a year free of self-harm or suicide before you could. So these are the treatment dilemmas. Luckily for us, at the time we were really getting stumped by this on our unit. The research was already coming out where people that were able to do randomized controls, which we're not a research, we're a hospital unit, so we can't randomize things that way. We're starting to show that it was safe to move the treatment closer and closer to when the last episode of self-harm. So there's a lot of robust evidence now that CBT or DBT with prolonged exposure, these are the treatments of choice for PTSD, for all kinds of PTSD, combat PTSD, rape victims, childhood trauma. And the pendulum, as I said, had swung in the 1990s to exclude individuals with SI, NSSI, serious substance abuse, and severe dissociation. So most of the kids that we see were excluded from having their PTSD treatment. And the current practice guidelines, which I don't think Edna's re-released, but she's part of these studies, so they will be re-released in writing, but they were that if significant suicidality is present, it must be addressed before any treatment is initiated. And so clients, adults, and kids with BPD have really been excluded from almost every study on the efficacy of PTSD treatment. So it left unanswered how to treat these kids. So this is the current exclusion criteria for prolonged exposure. Again, even though FOA is participating and doing it earlier and earlier, these are still the evidence-based treatment guidelines. So now it's serious NSSI in the past 3 months. It used to be a year. And substance abuse, severe dissociation. So these are better than they were before because it's 3 months now. And that allowed us to start to, I have the date wrong, this is 2012 now. It allowed us to start seeing if we could treat this more aggressively. Let's just discuss this because you have these in your books, the different methods, but the last point on here is the key one, which I think sort of integrates what all the speakers today have been talking about, which is it turns out that DBT, CBT, they turn out to be the correct primer treatments before you do PTSD treatment. So the truth ended up, sort of the clinical truth being a synthesis between this notion that you had to not expose people to memories, you had to not address this head on, you couldn't do any exposure or narrative work until people were safe for a very long period of time. It turns out that as long as they have skills on board, it's still true that you can't plunge into it without skills, but as long as the skills come before the exposure and they last, it looks like, for somewhere between 8 and 12 weeks. And we've even done some of this with kids that have only been free from self-harm 8 weeks now and have not had a bad event. Then you can go ahead and start to address the PTSD, which is not with DBT. This is just some other studies if people are interested that have looked at skills exposure model and the DBT first approach. This is what we're doing now. So this is how you start to try to integrate this. I guess my take-home message is that you have to do a very comprehensive initial assessment. I think just the way people for a long time ignored BPD features as an important cluster or diagnosis in adolescence and just fell back to the medical diagnoses that existed, like bipolar or depression or generalized anxiety disorder, or some sort of acute stress not otherwise mentioned anywhere, just to come up with a diagnosis that was not BPD. And I think that was an injustice and didn't allow the treatment, the DBT, to flow from that. It's the same thing with PTSD. Whether you're going to treat it or not, you need to know if it's there. And assessing it doesn't mean that you have an obligation to treat it before the child or adolescent is safe. There are still those exclusionary criteria. So if someone's psychotic or actively using substances or dissociating severely or has high self-harm on their diary card, it doesn't mean you have to treat it. What now has happened is it's become essentially a treatment carrot, a treatment motivator, because people suffer so much with PTSD. Interestingly enough, again, as Jill and other people have said, because the criterion behaviors for BPD often bring emotional regulation and relief, those behaviors are used to escape the PTSD symptoms. So if you're having flashbacks or nightmares or recurrent thoughts about a perpetrator, or you're avoiding everybody that has a beard and you're terrified all the time, and you're feeling very hyper-aroused, that's when a lot of these kids think of using self-harm or drinking or one of these behaviors to escape that. So it becomes a vicious loop. So what we do when they come in is we very carefully screen now to make sure of two things. One is we ask people about trauma, and we ask them without asking them specifics. So I can't emphasize that enough. We don't do it in an impartial, we do it in an impartial way. We don't suggest that because you have these symptoms or on this unit, we're very clear. We're not looking to make trauma where it isn't, and we ask them a very basic questionnaire at first that just doesn't ask you who did it, when it happened, how many times. It asks the adolescent themselves to rate the severity and frequency on a Likert scale from 1 to 5. It's called the Childhood Trauma Questionnaire. We also give the Risky Behavior Questionnaire. If they're identified as having had a trauma or not, they still do clinical interviews to follow up on that, and that there's a childhood trauma interview, which is one of Mary Zanarini's interviews, that's been adapted now, and that gives you an idea a little bit more specifically about what happened and when it happened, the category, was this familial, was it not familial? At the same time, it's not as specific as an instrument like the ACE because kids and adolescents are terrified of being traumatized by the disclosure process. So we try to walk the balance, saying to them, we want to know, but we want to know as much as you're willing to tell us if they've self-identified on the way in. And we discuss all the reporting issues with them before we even let them continue to talk with us or fill out these more specific surveys. So if they say, are you a mandated reporter? We'll say, only if it happened in Massachusetts. Do you have to do this? Do you have to do that? And we try to help them. We foreshadow for them what the disclosure process would be like if they want treatment and they want to tell us, because again, the amount of secondary traumatization that happens to kids who have no idea, they disclose, and 5 minutes later the police are called, is something we don't want to see happen. So we're trying to not have them not talk. We're trying to not have them say more than they're ready to say, because you can talk about a trauma on many different levels. You can talk about it, and you can have PTSD without telling anybody the specifics of it. So we want to know if there's an index trauma, and then we give them both the SCID, clinical interview, and a self-report. We want to know if they have PTSD, because again, about half of the kids with trauma either never had PTSD or don't have it by the time it comes on to they come onto the unit. And we also want to evaluate the impact of the trauma and the PTSD on their BPD and try to talk to them about how they see these facets as being interwoven. Because once you know this, usually children and adolescents will tell you, I do think that this memory, or I do think this event, or I don't remember feeling this dysregulated before this happened in my life. Other people will say, this happened at 13, but I remember being this dysregulated at 8, 9, 10, this sensitive. You can have both of them. Parental report is very important because sometimes you get a timeline that helps you clarify what has led to what. And so we're trying to validate the role of trauma, and we're trying to let them know there is an evidence-based treatment out there that they can have when they A, want it, and B, are ready for it in terms of being stable enough. So this is really telling people what's out there and that they have some ownership of whether they want that. These are the empirically supported features of CBT and DBT in adolescence. So I think the important thing here, I mean, this is all the way back from 2006. These were not kids who were ruled out, but that they all have some sort of trauma narrative, which is now called an exposure. But the important thing is you see the conjoint child-parent sessions. We have a big emphasis, again, same as Jill and Alec do, on parental involvement. You know, the idea that you can have someone's minor child in your program and launch into treating them for something that their parents may not know they have or why they have it just doesn't work, doesn't make any sense, and yet it's the balance between protecting their privacy and confidentiality, which is why we do this very stepwise sort of large sensitivity test. Did something happen? They can either tell you or not. They have many choice points. Then a more detailed interview about it that still doesn't ask for names, dates, et cetera. Then discussions with them that are educational about reporting guidelines, what the process of disclosure would look like. Get a sense from them about family involvement, letting them know their family will have to be involved if they're consenting to do trauma treatment. And then the work with the parents, which is what this is about, to try to get their buy-in to the treatment. So won't have time to go through all the permutations. There's obviously situations in which parents know nothing about what happened. There are situations in which something happened and the parents were involved and you're sitting with them and you know it, but it hasn't been said out loud yet. There's a lot of times when we're dealing with kids who've been hurt by someone else in the family and the parents don't know about that. There's a lot of other kinds of traumas. We see a huge amount of abuse by teachers, coaches, other significant people in kids' lives. Where that hasn't been disclosed yet, and the safety of other kids is going to be involved once the disclosure's made. So we say from the very beginning that parents are key sources of information. They're part of their lives. They're paying for their treatment. They're involved. And that we're not going to keep, you know, a high level of secret. If a kid wants to say to us something happened and I'm going to wait to talk about it when I'm 18 and my parents don't need to be involved, then they are free to do that. We see kids from 13 to 25. Kids that are over 18 sometimes elect to have their parents more or less involved. And we do a lot of work with the parents about confidentiality and privacy and how their behavior of trying to get answers that they have to tolerate. It's really distress tolerance for the parents, not knowing and allowing a procedure to unfold, or a relationship or a narrative that they're not necessarily either now or ever going to know the details of, which is very hard for parents to tolerate when they realize that somebody's hurt their kid in some ways. So we have family meetings. We have an actual written contract that the parent and kid sign if we're moving ahead with this that says what's going to be involved. And the importance of joint exposure and skill development at the end. We have a lot of families who have trauma that's multi-generational, which I'm sure won't surprise people here that work with patients that are traumatized. So there's been abuse in 2 or 3 generations of the family. The same person's hurt multi-generations. We also have kids that have suffered trauma in all kinds of ways. So one of the kids that Blaze and I worked with, he's still working with her, was a situation in which the father ran over, unfortunately, his toddler daughter 21 years ago came in saying that that wasn't relevant to the daughter we saw in front of us until we found out that his only daughter was killed. There were 3 boys. He had his vasectomy reversed. This daughter was the product of that reverse vasectomy to sort of save his wife's sanity, who had lost her only daughter, and she was named after the child that died. She and the mother had a special relationship talking about the child that died, and there were many more complicating factors, but that was a case in which the parents actually had never done any work around the loss of the child. The mother had gone to see her priest, the father had gone to work, and they almost lost their marriage. They felt the vasectomy and the child saved them, but in terms of the impact on the child that we were seeing, who was also sexually abused, that was not clear. So that was as much work with the parents as it was with the child. So the research is pouring in more and more strongly that you can do this integrated treatment with no worsening of the target behaviors and no increased dropout rate. This is this DBT protocol. This is what we're using on our unit now in a modified way. It uses standard DBT in combination with prolonged exposure of PTSD, and the remission rates, I mean, we don't have enough kids do that yet. This is from Harned, are actually coming in to be excellent. I thought I'd present one case to just give you the idea. This is the way we've modified the protocol. I don't know what to say. We've had to modify it a lot. We're hoping to at some point be able to do a more expanded protocol, but right now we're limited in terms of doing the number of in vivo exposures that Melanie and Marcia do, because our kids are trapped on a unit and they have to go out with counselors every time they do an in vivo exposure. So we've been doing a lot of the imaginal exposures to the actual narrative of the trauma. So this is sort of typifies, I think we have 7 or 8 kids now that we've done the full protocol on. There are most seriously self-injuring kids. You know what other people's experience. For us, kids with childhood sexual abuse, especially intrafamilial, absolutely come in with our worst levels of BPD criterion behaviors, worst self-harm, most severe, self-worthlessness, self-hate, huge amounts of shame. So for a number of these kids, I think now numbering 7, even though they had only been free of their target 1 symptoms for like barely 8 weeks, we're still having nightmares. Prazosin wasn't helping them, constantly suffering with PTSD symptoms. We got their parents' consent and their consent, and even though we were very unsure that they would be able to tolerate going right into talking about the trauma, because again, we didn't have a long lead up of doing a lot of practice in vivo exposures with them. So this was an 18-year-old female, really chronic suicidality and self-harm, horrible self-mutilation, serious suicide attempts. She was hospitalized, I think at Proctor probably, a few days after getting with us. We sat on the inpatient unit with her. She said, you know, I'm going to kill myself before I leave this place. And her childhood abuse was perpetrated by an older brother. She was the youngest of 10 kids in a devoutly Mormon family. We also get a lot of very religiously observant families, a lot of Orthodox Jewish families, Muslims, Mormons, and when that is a factor as well, it's particularly shameful. And so this kid, you know, again, any mention of it, she would say, it was me, I lured him into the bedroom, it probably didn't happen. Early on, when we included her family, 2 older sisters came forward and disclosed that the same brother had abused them. So that ended her doubt that what she remembered had happened. It was clear to us it was a memory. So she barely got to the 8 weeks in self-injury and suicidal behaviors, but she continued to have very high ideation, which is again where it seemed a little dicey, very high shame and guilt, and her PCL-C mean was 55. We could never get it down. That's very serious PTSD. So prolonged exposure was implemented, and this shows you her PTSD measures. I couldn't get them all on here, but week 4 was when we moved from doing just some practice with SUDS and getting her to practice talking about little fragments and using the tape recorder and doing some assignments about tolerating shame and difficult feelings. And it was only at the point that we started the prolonged exposure that her PTSD really started to go down. And she went, this shows her going down into the low 30s. 40 is usually the cutoff for clinical PTSD on this particular scale. Over 50 is very significant PTSD. So she no longer met the criteria after doing this. Her urges for self-injury and suicide, though, remained level both within and between sessions. She didn't act out with any self-harming behavior. She never missed a session, as difficult as it was. And what we did get an increase in sadness and anger at the perpetrator, which is what Melanie's work would predict. And we did not get decreases in fear, guilt, and shame, which we would have liked to, but again, we started this. We're not doing the full treatment yet. She left soon after that. We have stayed in touch with her, and she's actually continued to do very, very well. The PTSD, we found her DBT treater where she lives. She hasn't done more trauma work, but her symptoms have stayed in control. She hasn't had any more suicide attempts or self-injury. I think she's graduated from high school, yeah? So I think the take-home message of this is that we know that unprocessed trauma and PTSD are risk factors, both for the development of BPD in the first place, and they increase the severity of the Criterion behaviors. And I think that is just so obvious now across the whole lifespan. And that now, due to all the research, there are many more of these adolescents with trauma histories, PTSD and BPD, that would be eligible for integrated BPD and prolonged exposure treatment, and that it's an attempt to get their PTSD in control so that they learn skills, they do the exposure, then they go back to more traditional DBT in the hope that the PTSD symptoms will no longer be driving their Criterion B behaviors. And it's really showing very promising results in this population. So for us right now, the take-home message is, if we don't ask, we won't know. That we, feel that we swung back too far. There was barely, the psychiatrist would ask on the way in, history of trauma, yes, no. Often it wasn't read or picked up by people, and kids don't just come forward and say, I have PTSD. They don't even know what that cluster of symptoms looks like. They might say, I have a nightmare, and not tell you what it was about. You might know that they're avoidant, but you might not know what they're avoiding. They all look hyper-aroused anyhow, so that symptom cluster never made any sense to me. And so by asking them on the way in and then testing for PTSD, looking at it along with the development of the BPD behaviors, it really turns out that there are effective treatments for each of them. And the last slide's just, so we've expanded our research initiative now, and we're doing these assessments on first weekly and then bi-weekly. We've added a post-discharge follow-up, and we've added some laboratory-based assessments now, and EEG testing. We've hooked up with the Mood and Disorders lab at McLean. So again, some of the concepts that the other speakers were talking about in terms of dysregulation, what does skills actually get you? When the kid looks more regulated on the surface, are they more regulated because of your relationship, of the diary card, of the intensity of treatment, or has there actually been a biological shift in their sensitivity and in their return to baseline and how dysregulated they get? If we can find that at some point, it will even give us more hope that you can do other forms of treatment like the PTSD treatment if we could find a biomarker for introducing that. And then we're also looking at the interaction of medication with skill acquisition. So that's the story.